Hello, everybody, and welcome to The Wrap, brought to you by Michigan Medicine. I'm Jeremy Fowle, sitting in the hosting chair for today's episode.
And I'm Bailey Merzick, Jeremy's co-host for the show. Today, we're going to discuss pain management and how colleagues at Michigan Medicine are working to make it as safe and effective as possible for our patients.
Before we get into that conversation, make sure you go back and get caught up on any episode of The Wrap that you might have missed. You can find the shows on iTunes, Stitcher, Google Play, or any other podcast hosting platform. New shows can be found on the Michigan Medicine YouTube channel as part of the Headlines Week in Review.
All right, let's bring in Dr. Tricia Kiefer and Dr. Paul Hilliard. First, let's have the two of you introduce yourselves, and can you discuss your roles that make you experts in pain management?
Sure, I'm happy to take a start at that. I'm Paul Hilliard. I'm a anesthesiologist by training, and I have additional training by doing a pain fellowship. I have run the acute pain service, and I co-chair the institutional pain committee along with Dr. Kiefer. I also lead the institution's Rewrite the Script initiative and have been doing pain management for 19 years.
Hi, I'm Tricia Kiefer. I am one of the MedPeds palliative care providers here at the University of Michigan, and I'm the medical director for the Pediatric Palliative Care Program, which is one of the subspecialty pain management teams at the University of Michigan, but specifically serving our pediatric patient population. I co-chair, as Dr. Hilliard said, the pain committee with him, and then I also co-chair the pediatric pain subcommittee, and was part of the group that supported the Child-Kind work, which was a certification that our pediatric hospital gained last year.
So that's a terrific segue into our first question. And Tricia, you can kind of lead this off with us. What do you see as some of the emerging trends in acute and chronic pain management?
Yeah, I think for me, what we've focused on primarily in our pediatric world is novel ways to not use the opioid medications for pain. So in particular, non-pharmacologic therapies, use of distraction, massage, aromatherapy, a much more psychological approach to pain management has been really at the forefront of improving both acute and, in particular, chronic pain care.
Yeah, and I think that might be a good lead into our next question, because we were going to ask you what the challenges were, and I would imagine using those new methods might present some challenges sometimes. Can you talk a little bit about that?
You are absolutely right. Using non-pharmacologic therapies may sound easier than turning to medications, but is actually much more challenging because we often don't have people who are trained specifically in what those therapies are. And the data is still emerging, although what is available is fairly positive regarding the use of non-pharmacologic therapies. The focus has previously been on medical management and using our pharmacologic strategies in order to support our littlest patients. The other biggest issue is that even if we are able to access those resources within our own institution for our inpatients, it's much more challenging to access non-pharmacologic resources within the community in a way that's cost effective for patients and families who often are very stretched with their ability to obtain these services outside of our hospital walls.
Paul, is there a stigma to chronic pain management, and how do you and your group go about addressing this and trying to relieve some of that, some of the stress that might go along with that?
Yeah, without question, patients who suffer with chronic pain are stigmatized at many different levels. And, I think it takes an approach at each one of those levels. I think education is a key component of that. How we approach patients, even how we react to, looking at our schedule for the day. Whenever you're in the faculty room prepping with residents and that, I think our behaviors and attitudes are the unofficial, unwritten curriculum that learners follow. And so I think, without question, there's stigma, no doubt about it. And I think our part in this is recognize, this patient, if they were given a choice, probably wouldn't want to be in our clinic today. They probably didn't choose to have chronic back pain or be beyond a certain therapy. And so I think it's just important to model compassion and patience. And I think that setting an example and teaching our learners and others around us, even more seasoned professionals, pick up on that vibe. And I think each one of us has an opportunity to set the tone for those patients. And so, yeah, stigma, no doubt about it, a huge challenge with chronic pain management.
So going into your work, do you have an example of helping a patient or a caregiver who is struggling with pain and having them successfully find a way to address their challenges?
I'm sure we both have examples. I'm going to share one that was brought up recently from the inpatient setting. We were caring for a patient who had a very prolonged admission with sickle cell exacerbation and also had chronic pain. We saw this patient numerous times, and when I came onto service, she'd been in the hospital several weeks. And despite having escalation of care and a lot of pretty advanced therapeutics, she was still rating her pain as a 9 out of 10 using that numeric pain scale. And I went and spoke with her, and in the middle of our encounter, I said, I just want to apologize. It looks like we're failing to meet your needs here with pain management. And she's interrupted me and said, no, this is the best my pain has ever been managed. You don't understand. People are listening to me. They're trying to help me. And so, it's I think is reflective of the complexities of pain management. It's a sensory and emotional experience. And so it's not just what patients are feeling physically, but how they're feeling in terms of their well-being. And I think our team did a great job in that case, although we were not addressing the sensory component adequately with the tools we had. She felt cared for, and she felt like that there was a team approach. So you're probably looking for a more concrete example than that, but I think that was a victory because some conditions are very painful, and we can only go to a certain point with our therapeutics before they become toxic to patients and actually cause harm. And sometimes we do reach that ceiling, but there's often more that can be done just by listening, just by, bringing some of those other tools. And I think us as providers, we are a non-pharma modality. So the way you look at patients, look them in the eyes, pay attention to them. I think these are all things that can help. And so I would say that's an example. And I don't mean to imply that it was me who change the course for this patient. It was all the work leading up to when I was there. So everybody, her experience was people were listening to her. They're trying to help her. And I think that was a big victory for pain management, despite what the numbers may show. And, I think it also highlights the challenges of using assessment tools that are so binary.
Tricia, did you have an example that you wanted to share, one that kind of stuck out to you?
I can think of a lot of examples where approaching malignant pain with, sort of a different lens can be really important, in particular in kids with serious illness. But the example I wanted to bring up is actually an example of a patient with non-malignant severe pain. And I wanted to bring it up specifically because what it showed was really the sort of Better Together model over at Children's and Women's, because this was a patient who, upon assessment, the palliative care team was one of the last teams to be involved in his care. It was highly appropriate for every single team that had been engaged in the care of this patient with a serious but non-malignant illness. And so it was really gratifying to go through his pain assessment and talk about all the things that he had tried. He had come from an outside institution. He had tried virtually every non-pharmacologic option in the toolkit that we have, including child life, pet therapy, art therapy, working with virtual reality, working with our psychology team. He had the acute pain service involved, and also been working with our acute pain service nurses, and was on one of the floors that it has a champion in our PRN nursing program. And all of this helped support his pain. And then we just sort of put that final piece in, which helping bring that together for him and talk about how to use all those, and then adding a medication, which I know I said that non-pharm is actually the most important thing, but in this particular instance, moving him from a traditional opioid to actually using a medication called buprenorphine, excuse me, for it's a bit of a mouthful, but ended up really being the final thing in that huge multimodal plan for him that ended up supporting him to be able to get home and to manage his pain at home. And so I feel like that's one of those places where I can see where our team and our engagement made a big difference, but I could also see where every other team had impacted him as well. And that was really incredible to see.
Those are two wonderful stories, and just speaks to the volumes of work and kind of the interdisciplinary nature that goes into this process. And I kind of want to throw it back a little bit, and I want you both to think back to how everything kind of got started for you, because I'm sure the beginning of your career is a lot different than the current one, and we'll get to that in a little bit. But as clinical experts, in pain management here at UM Health, like what led to you, being leaders in the space, and how do you think you got here? And Paul, maybe you can kick us off on that.
Yeah, thanks for the question, Jeremy. I think for me, it was a combination of interest, luck, and hard work, and I think it's a partly just being in the right place at the right time for becoming, in a leadership role of this, but also just having I think a deep passion for this work. For me, it began before medical school. I had an interest in pain management. I read a book called The Gift of Pain by Dr. Paul Bryan, who is a surgeon who spent his career in India working with Hansen's disease or leprosy, and noted how devastating it was when patients stopped feeling pain. And it just sparked an interest and a curiosity in me. I really never thought it would be a career path for me, but it was an interest. Then in medical school, I started to gravitate towards the operative side of things. One thing led to another, and career in anesthesia and then pain management. As far as the leadership path, again, I think it's a combination of hard work and good fortune, being in the right place at the right time and doing work that was meaningful. Others recognized that and saw value to it. And when doors opened, I would walk through them.
So my path was maybe a little bit less direct. I think as a trainee, I shied away from pain management and was really frustrated by it and found it to be a big obstacle, and just didn't quite know how to overcome that. And my path for other reasons led me to palliative care, and really the focus on symptom management and how important it is for patients to have really good symptom management when they have serious illness, and especially if we want to engage in discussions about quality of life and their values, really helped me see the value of, diving in and getting to sort of know as much as I could about pain management and to take on as many of those cases as possible to be able to know and understand how I can actually make a difference. And I think since then, a number of people have inspired me, but in particular, one of the nurses on our team really highlighted a lot of the issues and the things that brought to the forefront. And through a lot of our conversations and hard work as a team, that helped me sort of drive forward in figuring out how can we support Michigan medicine to continue to evolve in the pain management space.
So lastly, I know you guys touched on this a little bit. What are some of the latest pain management research, tools, techniques that you find to be promising here in the near future, and what might be aspirational, in addition to what you mentioned earlier?
Yeah, I can take a first go at this. I think there's been remarkable progress in certain pockets of pain management. So pain is a huge topic. It's like saying car. Are we talking about sports car? Are we talking about four-wheel drive? Are we talking about sedan? It's a huge topic. And so I think that there's not one global approach to pain that I see as really earth-shattering, but I think I'm definitely seeing pockets and areas where remarkable progress is being made. And I think one area that strikes me most perhaps is in the last 2 to 3 years, the pharmacological advances in headache and chronic headache management. Tremendous number of options have come to market everything from intranasal ketamine to some of the CGRP protein blockers and things. Just a real hot area of research and development. I have not seen that in other pockets of pain management. So, I think we're seeing areas where there's remarkable progress, and I think there's areas where there's a lot of work to be done. Looking to the future, I'm very, very interested to see how AI will start to inform clinical decision support and evaluation tools as well. Other interesting areas include more use of distraction techniques like virtual reality, and especially as that relates to some of the behavioral health components of pain management. So I don't see one thing per se, but I definitely see pockets of really interesting and emerging work and technology.
I echo everything that Dr. Hilliard said. And I would say sort of in the pediatric world, I think we're also seeing enthusiasm about some of our therapies that have been more traditionally seen in the adult setting, some of our regional blocks, and then the use of the medication I was talking about earlier, buprenorphine, in a younger population is probably sort of the leading edge of where pain management is going from a pharmacologic or interventional perspective. I mean, as we were talking about before, I think a lot of the non-pharmacologic strategies, as we continue to get more information about what is the most effective and how to make it the most effective, but in particular, the sort of intensive psychologic support for patients with particularly chronic pain, and particularly children who have varying different developmental stages and different approaches that need to be taken for these, I think are really what we're hoping for to see sort of gather the most support, because they've proven to be the most effective in our patient population.
Thank you for those wonderful answers. There's a lot to look forward to, and the work that you're doing has been tremendous. So thanks for everything that you're doing. And I want to thank you both for joining us and discussing this important topic. And for folks at home, if you want to learn more about pain management, Michigan Medicine, we have a bunch of stories on headlines that you can find at mmheadlines.org. That's mmheadlines.org.
Okay, it's time for the lightning round when we ask one of our guests 4 quick-fire questions. Dr. Hilliard, you're going to be in the hot seat today. Are you ready to go?
I'm ready.
All right, so fall officially started last weekend. Apple cider, anything pumpkin spice, things of that nature. What is your favorite fall drink, or are you going off the board with something else?
I know this is a controversial one, but I just love the pumpkin spice latte. Maybe I'm just a simple person, and I maybe reveal too much about myself, but to me, I just look forward to that every year.
Okay, well, you were ready for that one. So let's stick with the food theme. Earlier this week was National Pancake Day. What is your favorite breakfast food or breakfast meal?
Easy, French toast.
Done up anyway, just syrup?
Just French toast. My grandma used to make it Texas toast, really thick slice of bread, nice crisp on the outside, and it almost didn't matter what you put on it. The toast by itself was so good. So yeah, French toast.
Perfect. Well, you kind of alluded to this earlier. You didn't even know we were going to ask this question, but we ran a story about the auto show charity preview. And of course, the Detroit Auto Show just wrapped up. So are you into cars at all? And if so, what is your dream vehicle?
I'm into cars, and they're all my dream vehicles. To be quite honest with you, I think at different phases of life, I've had different dream vehicles. So my passion is to kind of go old school, manual transmission with no radio on, no nothing, and just enjoy going through the gears. Not something too powerful, but something that makes you get through all the gears. And so I actually prefer a fairly simple car, usually something European and something small.
All right, and finally, if you could go back in time and meet one person from history, who would it be and why?
I suppose I would like to meet my great grandfather. It's I would love to know more about my own family and the origins, where we came from. My family name was Boucher, and legend has it he was a stowaway on a ship somewhere from Wales, but we think he was French. And when he got here, he died. And my grandfather, who had just been born, took the family name Hilliard. And so I really don't know much about that side of my background. So I'd like to meet my great-grandfather.
What wonderful background. Yeah, that'd be great to know. Thanks for sharing that, Paul. Thanks for playing. It's hard to be in the hot seat, but I think you handled it really, really well. And thanks to you again for this important conversation. And once again, we'll direct you back to mmheadlines.org.
And while you're there, you can check out this week's featured stories, which included an invitation to the upcoming DEI symposium and a look at the state-of-the-art cancer care center being delivered at the Brighton Center for Specialty Care and University Hospital. Find all that and more at mmheadlines.org.
Okay, Bailey, we asked Dr. Hilliard about what his dream car would be. Are you into cars? And if so, what do you like driving around?
I'm not really into cars, but I would love to have some kind of convertible, especially this time of year, to just drive with the top off and look at the fall colors and with a nice cool breeze. That would be awesome. And what about you, Jeremy? Are you into cars?
I'm not into cars, but I do like something smooth and comfortable. But if I had to like I'm thinking about like my childhood fantasy type thing, I would have to pick something sporty. And I guess right now like a Porsche 911 or something like that would be a lot of fun to zip around in. Something that handled really well and went really fast and like you really didn't feel anything. That would be pretty cool.
All right. Well, it's time for the weekly trivia contest. And this week's question is, what is the theme for the upcoming DEI symposium on October 20th? Once again, what is the theme for the upcoming DEI symposium on October 20th? You can find the answer in this week's headline story, and once you know it, send it to headlines@med.umich.edu for the chance to win a prize.
And that's all we have for today. Thank you to Dr. Hilliard and Dr. Kiefer for joining us. And thanks as always to all our listeners and viewers for everything that you do for our patients, families, and each other. We'll see you again next week.